Today's webinar is being presented by Stephen Hare. A graduate of the University of South Carolina's Medical School and Palomento Richland Memorial Residency Program, Hare is currently the Chairman and Medical Director at Morton Plant Hospital in Clearview, Florida. Additionally, he's the Chairman of Pinellas County EMS Medical Advisory Board and the co-chair of the Sepsis Committee for the Morton Plant Emergency Department. Thanks again for joining us for today's webinar. At this point, I'll turn the presentation over to our speaker.
Good afternoon, everyone. My name is Dr. Steve Hare, and I'm very excited about speaking to you today regarding early recognition of sepsis in the emergency department. I am a clinician. I do practice in the emergency department. I don't just practice being a chairman. I see patients several times a month and do several shifts in our emergency department. A little bit more about me before we start. Originally from Youngstown, Ohio, and then, as mentioned, did my undergraduate at the University of South Carolina, my medical school there, residency as well, and then had one job, which has been at Morton Plant Hospital in Clearwater, Florida. Previously mentioned, I think it was Clearview, but that is actually Clearwater, Florida, and that's on the Gulf of Mexico. This is the hospital that I practice at. It says experience 2008 to 14. That's when our sepsis program really got into high gear. I've had this single job for the past 17 years. It's a fine place to work. We've got an excellent lab department here, excellent administration, emergency department, and ICU. Just an overall fine place to work. Our emergency department sees about 150 patients a day, which is about 55,000 a year. Our admit rate is 33%. We have a 40-bed emergency department and 600-plus beds upstairs as inpatients. We have all the disciplines here, cardiac surgery, neurosurgery, except for pediatrics. So this is the facility that I work at. Our objectives today are to discuss procalcitonin and how it's used in sepsis, describe PCT ranges and levels associated with sepsis, severe sepsis, and septic shock, describe the performance characteristics of the biomarker procalcitonin, PCT, and how it complements the ED assessment of sepsis. There will be a couple repeat slides along the way. I really want to hit home a couple points, so if you see things once or twice, that's the reason why is that I do think they're important take-home points. Sepsis is very costly. $17 billion is the estimated cost a year. The average cost of treating a septic patient is $50,000. It is 40% of the total ICU expenditures. Greater than 50% stay in the ICU longer. In other words, the hospital length of stay for folks in general is 7.2. For septic patients, it's 11.2. And their ICU stay is 6.5 compared to 4.2 days for other type patients. Sepsis is deadly. It's the 10th leading cause of death. It is similar to acute MI and far surpasses breast cancer and AIDS. 215,000 deaths per year attributed to sepsis. It's very difficult to diagnose. SIRS criteria are very nonspecific, and they present in many patients independent of sepsis. Microbiological proof of the infection is often negative, where the availability is quite delayed in getting. 10% of septic patients do not even receive prompt antibiotic therapy, increasing the mortality by 10 to 15%. Sepsis definitions and diagnostic criteria. Sepsis is a combination of SIRS and infection. The American College of Chest Physicians and Society of Critical Care Medicine came up with this in 1992. The SIRS criteria are temperature greater than 38 degrees Celsius, which is 101 degrees Fahrenheit, heart rate greater than 90, tachypnea greater than 20, leukocytosis greater than 12 or less than 4,000, or the immature neutrophils, as you see. And this is a point I want to talk about and drive home a little bit, so you may see this slide a few times. Sepsis equals SIRS, systemic inflammatory response syndrome, plus infection. That then progresses to the next step of illness, which is severe sepsis, sepsis plus organ dysfunction, and finally, severe sepsis plus hypotension in spite of fluid resuscitation. Again, seen in a different schematic, patient becomes infected with either bacterial, viral, fungal, parasitic infection. They develop the SIRS criteria, as we just talked about with the heart rate, the temperature. This then progresses to severe sepsis with at least one acute organ dysfunction, and we'll get into that shortly. And finally, unfortunately, into sepsis-induced refractory hypotension, unless we can intervene early on. Again, 10th leading cause of death. It's a very common cause of organ dysfunction, increased cost of care, and increased length of stay. So rather than trying to find a magic bullet to cure sepsis, the magic antibiotic, maybe we should focus on early recognition so we can get the treatment on board. Wouldn't it be nice if we knew that the patient had a bacterial infection that we could treat with antibiotics? We had an additional piece of clinical information to help with the risk assessment, and you had a 20-minute test that's elevated in the presence of severe systemic bacterial infection. And that's a key one there, bacterial infection. Undifferentiated patient presenting to the ED. This is my favorite slide. I don't know about the other clinicians out there, but no one has ever walked in. I walk into the room to take care of them. They say, "Doc, I think I have sepsis today." Patients don't tell you they have sepsis. What they do tell you are other things. So this is our pause for humor right here. I have a top 4 list of things that patients have told me they had when I went in to see them in the emergency department. So perhaps at the end you could give me one that I can fill in for my 5th. The number 5 one, or number 4 in this case, is fireballs in the uterus. That would be fibroids in the uterus. The second was a patient, I spoke to the mother, and she claimed that the child had screaming mighty Jesus as a child. That would be spinal meningitis. The next one of my students went in, came out, and put their hand just below their breastbone, and they said that the patient had told them that they had a hiatal hernia. That would be a hiatal hernia. And the last one actually came from my wife. My youngest had some hip pain, lasted for about 24 hours. Didn't seem to get better with Motrin. We ended up at the pediatric orthopedist office, and he felt that she had a hip infection that is called toxic synovitis. Goes away in 24 hours. My wife, on the way home, told her friends that my child had gastric synovitis. I'm not sure where that one came from. And the point of this is patients don't always tell you what they have. They may hear one thing or hear another. They may come in and tell you that they have a respiratory infection, that they're coughing, they don't feel well. Well, if it's viral, there's no biomarker to measure that, but if it's bacterial, we have PCT. If it's non-infectious, if they've been on a trip somewhere, they've got a history or a reason to suspect they might have a pulmonary embolus, you could get a D-dimer. If it's cardiac, we can check for congestive heart failure with a pro-BNP, or check for an MI with an elevated troponin. All of these are great tests. Certainly being a clinician, I hold my clinical examination and history with all of these biomarkers as well. The ideal biomarker would be objectively measured and reproducible. It would be an indicator of normal physiological processes, pathogenic processes, and there'd be a pharmacological response to a therapeutic intervention. It should reflect underlying biological processes, predict clinical events, should be obtained quickly and reproducible, and it should be affordable. Some commonly used biomarkers right now include troponin. As mentioned, if it is elevated, you should be concerned about either a non-ST segment elevation MI or an ST segment elevation MI, as you see in this slide. BNP, if it's elevated, certainly be concerned for congestive heart failure. Procalcitonin, if that's elevated, concern for bacterial infection. Procalcitonin is present in normal tissue, in healthy tissue, but it's also present and increases when there's bacterial infection. Thyroid, as you can see, has it both in healthy tissue and with infection. It elevates and is produced by the colon, the testes, the adrenal, many, many different organs. It's produced by numerous organs at the cell levels after the inflammatory stimulation. The PCT rises in about 3 to 6 hours, half-life somewhere around 24 hours. Early identification and risk assessment provides us the opportunity to jump on those patients and start immediate care. It is cleaved intercellularly. During severe infections and sepsis, procalcitonin plasma levels may increase to over 200. I have fortunately not seen one that high, but they certainly can get that elevated. The increase in procalcitonin level is not accompanied by an increase in plasma calcitonin levels. And again, half-life around 24 hours in the bloodstream. All right, procalcitonin and lactate. It does not take the place of lactate. It is complementary to lactate. Procalcitonin is an early marker. It's present in severe bacterial infections, especially early on in the course, as a reaction to the infection. The higher the PCT, the higher the risk. Again, these results are long available before any microbiological confirmation. It also helps differentiate patients with sepsis from those with non-infectious SIRS. Lactate is more of a late marker. It's a metabolite reaction to non-perfusion of organs. Severity marker in septic shock, as we all know, and we'll go through a little bit of that shortly. It does respond to fluids, and it does respond when there's vasopressor support. I'm sure we all know it's part of the early goal-directed therapy and the Surviving Sepsis campaign as well. Procalcitonin, however, is more specific for the diagnosis of sepsis. Again, driving home a point, it does not replace lactate, nor does it compete with lactate. It gives you a more clear picture of what may be going on with the patient. As you can see, true positives are higher with procalcitonin versus more false positives with lactate. Serial measurements of blood lactate can help guide your therapy. They are a predictor of mortality. The higher the acidosis, greater than 10, 95% mortality. 5 to 10, about 60 to 75. 2.5 to 5, 25 to 35. And less than 2.5 is normal. This is a busy slide. Well, what I can tell you is how I use the PCT value. If I get a patient that comes in and their PCT value is less than 0.5, I'm pretty comfortable that there's not a severe bacterial infection going on. Certainly continue to use my clinical judgment. If it's greater than 0.5 to 2, still probably not, but something now that is entering my thought process a bit more. Greater than 2, then I start to turn over all of the different stones that may be causing sepsis. And certainly when it's greater than 10, I have significant concern for trying to find what is causing the infection. As you can see, healthy individuals in this slide, again showing the same slide in a different way. Less than 0.5 is okay. Elevated levels indicate bacterial infection accompanied by systemic inflammatory reaction. PCT's levels increase with progression of the disease from sepsis to severe sepsis and septic shock. It can be elevated in different situations, though. Neuroendocrine tumors, non-infectious inflammatory responses such as post-cabbage, trauma, burns, and values may be elevated in renal failure I have not seen that too often with the renal failure. This is a slide showing how the procalcitonin would rise with sepsis, secondary to community-acquired pneumonia. That's what CAP is. Over the course of the 24 hours, it rises to a peak, and then as treatment is given to the patient, the PCT level drops off. I truly enjoy this slide as well, and it shows that highly specific induction or release of PCT due to bacterial infection. Interferon gamma is released in viral infections, thus blocking the activation of PCT production. Therefore, in viral infections, PCT is low versus a severe bacterial infection where that elevates, that being the gray versus the red bar graph. There are some false negatives, as we discussed. Always keep those in mind. A very early infection, a localized infection, such as an abscess sometimes, or subacute bacterial endocarditis. In addition, newborn, ARDS, chemical pneumonitis, acute malaria, systemic fungal infections, trauma, antithymocyte globulin, burns, pancreatitis, and a few others, as you can see on the right part of the slide. So let's talk about clinically how we put this process together. As you saw from one of the very first slides, it was 2008 when we started this process, and we worked with our intensive care physicians, and we worked with our hospital, and then went on a multidisciplinary approach and worked collaboratively with all of the other folks that we need for support, and that would be everyone from registration to environmental services, patient care techs, nursing staff in the emergency department, primary care physicians, ED and ICU nurses, obviously intensivists, and what's called our administrator on duty. We created a sepsis screening tool, and we launched the sepsis plan. Therefore, when patients would come to the emergency department, we would screen them immediately to make sure that they do not fall into a new infection and one of the following SIRS criteria. SIRS, again, being temperature greater than 101, heart rate greater than 90, respiratory rate greater than 20, white blood cell count of 12,000, with some altered mental status, changes, or plasma glucose. To be considered severe sepsis, you would also have to have evidence of one of the sepsis-induced hypoperfusion or non-chronic organ dysfunction due to that new infection. And as you can see, that's lower systolic blood pressure, a change in creatinine or bilirubin, in addition, a lactate above the level of 2, platelet counts less than 100,000, decreased urine output, a coagulopathy greater than 1.5, or lung injury. That would qualify you for severe sepsis. The rest of this page shows this. If that is the case, make sure within the 3 hours that you measure the lactate level and the procalcitonin level, obtain your blood cultures, administer the broad-spectrum antibiotic. If the patient has hypotension and you suspect infection to begin with, then you should administer the 30 mLs per kg crystalloid bolus. Or if their lactate is greater than 4, you should administer that bolus as well. Now, if after giving the 30 mLs per kg that their systolic blood pressure is not above 90 or their mean arterial pressure not above 65, then you should insert a central line. Inserting the central line, also then measuring the CVP and measuring the SCVO2. There is one other factor within this, and that is remeasuring the lactate if the initial lactate was greater than 2. That one we tend to struggle with because of the transition of the patient from the emergency department to upstairs. Our newest process is going to be one in which that is ordered shortly after in the emergency department to assure that we're hitting that target. That resuscitation bundle and the process that we came up with obviously measures the serum lactate, so we're in the Surviving Sepsis campaign. we obtain the blood cultures, we treat the hypotension or an elevated lactic acid greater than 4 with 30 mLs per kg of fluid. That's one that has been a challenging point to take home, is treating that hypotension, and checking for the elevated lactic acid. And if it is positive, giving the 30 mLs per kg. You have to start right away with either a large bore IV or 2 large bore IVs, getting that much fluid into the individuals to make sure that you're within the resuscitation bundle. The next one is what you complete within 6 hours, and that's the vasopressors if there's refractory hypotension. If the initial lactate is greater than 4, you should be putting in your central line. Measuring the SCVO2, you should remeasure the lactate, and this is a typo, if it's greater than 2 initially. We just talked about that transition process. And then also, the goal is to achieve a CVP greater than 8 or an SCVO2 greater than 70. Unfortunately, if you don't do this, this is one case in which you would fall out of the bucket, because the bucket of success, that is, with the Surviving Sepsis Campaign bundle, because you didn't achieve a certain level. And this is different than an acute MI. An acute MI, you diagnose a patient, you get them to the cath lab, you open up the arteries within 90 minutes, or you have a balloon within 90 minutes. There's success no matter what the outcome is. With the Surviving Sepsis Campaign, we're also measured upon how the patient responds and what the mortality is. Our ED Sepsis Power Plan is compliant with the Surviving Sepsis Campaign bundle. Obviously important to insert the central line, 30 mLs per kg. Big one there, measuring the CVP and the SCVO2 and assuring that the patient gets antibiotics. Those are some key drive-home points there. Now, how do we put the process in motion? We have a team member that would stat page a primary care physician. They have 15 minutes to return that call. And then also stat page the intensivist on call or who is ever designated by the primary physician. If that physician does not return the call within 15 minutes, we initiate our ED sepsis call matrix. Using the on-call physician and the on-call intensivist, we determine the need for a central line, the timing of that line, where the line is placed, how the SCVO2 and CVP are going to be obtained, and then respiratory therapy is also notified to see if we need their assistance. The other person that's important in this is our administrator on duty. The individual that is looking for bed availability in the ICU and letting us know the expected time that that bed may be available. Why don't we do a few case studies? The first case is one of a 53-year-old gentleman, shortness of breath, sudden onset about 6 hours prior to presentation, mild chest pain, no fever, slight cough. The patient has a past medical history of asthma, coronary artery disease. Past surgical history is negative. Medicines include prednisone, nitroglycerin, and albuterol inhaler. The patient does not smoke and does not drink alcohol. Temperature is 99.9, heart rate 105, respiratory rate 18, blood pressure 150/86, O2 sat is 91. Physical exam, heart, regular rate and rhythm. Lungs have a mild wheeze. Extremity with no edema. Clinically so far, perhaps a concern for infection because of the cough and congestion. One of the SIRS criteria, heart rate greater than 100. However, no other SIRS criteria. The labs, white blood cell count of 15,000, BNP that is normal, urine that's normal, EKG, sinus tachycardia, rate of 105, displaying S1Q3T3 type configuration on the EKG, lactic acid 1.0, and PCT less than 0.5. I certainly remember this patient. We received our PCT and lactic acid back. The concern for sepsis significantly decreased. Combining that with some other key history and an EKG with the S1Q3T3, chest x-ray is up for your viewing. Give you a moment to take a look at that. CT scan was obtained after the chest X-ray, which, by the way, the chest X-ray is normal. The chest X-ray was positive for a pulmonary embolus. Going on to our next patient. This is a 68-year-old that presented with subjective fevers at home, 2 days of sore throat, mild cough, and congestion. Past medical history as a pace replacement. No medications. Vitals, temperature, 101. Heart rate, 96. Blood pressure, 148/78. Respiratory rate, 16. O2 sat of 96%. SIRS criteria. Temperature is elevated a little bit, but the heart rate, with it being 96 as well. The temperature is 101, not over the 101 threshold to be in the SIRS criteria. Physical exam, heart rate, regular rate and rhythm, lungs cleared auscultation bilaterally, or a pharynx with exudate on the tonsils. No chest X-ray here. Labs with blood cell count of 12,000. BNP is normal limit. Lactate of 1.8. PCT 0.5. This is when we need to use our clinical diagnosis. This patient has clinical strep laryngitis. Next case is a 68-year-old with cough, shortness of breath, congestion, subjective fever, just not feeling well. Past medical history includes CHF, COPD, diabetes, medications, prednisone, albuterol, and digoxin. Vitals, temperature 100, respiratory rate of 18, blood pressure 180/100, heart rate of 90, O2 sat a little bit low at 91%. Heart, regular rate and rhythm, 2/6 systolic ejection murmur, lungs roused bilaterally, extremities with some swelling bilaterally. White blood cell count of 10,000, BNP is normal, BNP 955, PCT is 1.5, lactate of 1.7, and a digoxin of 0.5. Chest X-ray is seen. A few minutes to look at that. Diagnosis, clinical congestive heart failure. In addition, labs supporting these diagnoses. Next one is a 78-year-old who presented from the nursing home resident. We get quite a few of these. They presented secondary to just not acting right. It's been going on for the past 12 to 18 hours. Fevers of 103, positive nausea and vomiting, shortness of breath, cough, past medical history, CHF, dementia, and coronary artery disease. Past surgical history is a pacemaker. Temperatures 103.8, respiratory rate 25. We have 2 SIRS criteria plus the mental status changes. Heart rate 115. Physical exam confused or pharynx is dry. Heart, tachycardia. Lungs, bronchi and roused. The abdomen is benign. Extremities with some slight edema. The patient was given solumedrol, a breathing treatment. Gingerly given some IV fluids as we determine what may be going on. No improvement, and the patient was intubated. Patient came back with a white blood cell count of 26,000, BNP, sodium of 130, BUN of 51, creatinine of 2.5, which is new. Now we're into severe sepsis. The patient had more than at least 2 of the SIRS criteria, and now has evidence of non-chronic organ dysfunction by the creatinine being 2.5. In addition, a very concerning lactate of 3.9, but even more concerning is the PCT at a level of 14. This is the patient's chest X-ray. The patient did receive IV fluids. The patient's blood pressure never dropped, the lactate being less than 4. The patient did not receive a central line, but they do have a diagnosis of severe sepsis and, of course, received antibiotics. Case number 5, 58-year-old presents with not feeling well for the past 18 to 24 hours. Weak, cough, nausea. Past medical history and past surgical history are negative. The patient is a smoker. Vitals temperature 102. Blood pressure 146/86, respiratory rate of 18, heart rate 110, O2 sat of 92. Physical exam, the oropharynx is dry, the heart is tachycardic, the lungs have bronchi. Labs, white blood cell count is 18,000. Sodium, 131. Lactic acid, 2.4, and a PCT of 4. Lactate below the septic level. Chest x-ray is shown. Give you a moment here to take a look. Temperature was greater than 101, respiratory or heart rate greater than 90. Those are your SIRS criteria. Lactic acid greater than 2. Now they qualify as having pneumonia with severe sepsis. Remember to recheck that lactate as the lactate was greater than 2. Our final case, a 35-year-old male, history of weakness, cough, fever for 2 days, poor PO intake, no vomiting. I remember this case quite well. Past medical history is negative, past surgical history negative, social, occasional alcohol, but no tobacco and no drugs. Sweating profusely when he came through the door, placed in one of the beds, chart picked up immediately, and I went in to speak with the gentleman. Noticed his vital signs of 103.8, increased respiratory rate, but not working excessively to maintain his oxygen level by any means. Blood pressure is a little bit on the low side, systolic, 106/74. Heart rate 130. The O2 sat was about 92%. Extremely sweaty, oropharynx dry on physical exam. Heart tachycardic, no murmurs. The abdomen was soft, and there was no rebound. Labs, white blood cell count of nearly 19,000, hemoglobin of 10, hematocrit of 29, platelets of 94. BMP with an anion gap of 15, carbon dioxide of 14, BUN of 38, creatinine of 2.1, Billy of 1.8, AST of 1577, patients screaming of sepsis. Lactic acid of 4.1, qualifying in many different ways for septic shock. Procalcitonin 11.56, very much concerned for sepsis. ABG wasn't too bad, again maintaining 733, 30, and 70, not showing excessive work to maintain his airway. Patient was given Motrin, 30 cc per kg, bolus of normal saline was given, continued to tachypneic, did not need intubation. Subclavian central line was placed as per the sepsis protocol. Recheck vitals, temperature 101, respiratory rate of 20, blood pressure has not made much movement, 108/78. The heart rate's 130 still, despite all of this fluid. SAT's 98.4%. Repeat BMP 6 hours later after the fluids. anion gap still 15. Bicarb fell to 13. PCT up to 14. Lactic acid to 9.9. Chest X-ray, this was done prior to the insertion of the central line, is seen. I remember vividly calling the intensive care physician, discussing the case with them and concerned for what ultimately was, unfortunately, the diagnosis. The patient went to the ICU. The patient had a stat echo performed, was found to have vegetations on the mitral valve, group A beta hemolytic strep, causing septic shock. But we were able to identify and treat this patient aggressively with antibiotics, and this patient had excellent treatment and excellent throughput through the use of procalcitonin PCT. We've made great strides in our process in identifying these patients. Our turnaround time for the PCT is roughly about 30 to 45 minutes from after seeing the patient, letting the nurse know. The running time of the actual specimen, roughly about 20 to 30 minutes, we see with our turnaround time. But it has become an excellent use for us in identifying those patients, again, that have bacterial infections, and that it is noticed early on in the process. Early recognition is the key. It's the key to diagnosing and treating our patients, and that results in fewer inpatient days, ICU days, and cost of care. But most importantly, number one thing is to reduce mortality in the patients that we have the privilege to care for. I thank you very much for joining me today, and hope you had some education and some laughter along the way.